The concept we are reviewing today is perfusion, and your reading assignment is the Giddens material under Concept 15 and Yost chapter 38. Whatever you didn't read under oxygenation, now read under perfusion. This slide has the objectives for this lecture: to understand the concept, to recognize conditions that place the patient at risk for perfusion imbalances, to identify signs and symptoms, and to apply the nursing process of assessment, planning, intervention, and evaluation. Here is a list of YouTubes that you can view when they come up within the lecture. I put them here so that you'll make sure that you don't miss them. Most are fairly short, but should help with your understanding. These are the key points to understand, and you can read these now and read them again at the end of this session. Giddens' definition of perfusion is the flow of blood through arteries and capillaries, delivering nutrients and oxygen to cells and removing cellular waste products, something that you already know. But specifically, perfusion is about blood flow to tissues and organs to supply oxygen and nutrients while removing waste products. There are three major disease processes surrounding the concept of perfusion, which are altered perfusion to the heart or coronary artery disease, altered perfusion to the brain or strokes, aka or CVAs, and to the body or peripheral vascular disease. Signs and symptoms are different, and interventions also differ. But one thing they all have in common is that altered perfusion results in pain. The subconcepts of perfusion include pump performance, vascular tone, and volume of blood. So we'll be looking at each of these as we go on. So think about what needs to be in place for perfusion to occur optimally. And these are your antecedents that are listed as a functioning cardiopulmonary and vascular system, adequate fluid volume, and no clots or sclerotic blockages. These are the areas that we will need to strengthen with our nursing interventions. Slides 12 and 13 look at the attributes of perfusion, which can be either signs and symptoms or goals for the patient to attain. Signs and symptoms or attaining goals reveals to us that our patients are experiencing optimal perfusion. So the attributes are blood pressure within normal limits, having a brisk capillary refill, having strength of pulses within normal limits, and a MAP or mean arterial pressure that is greater than 60 millimeters of mercury. If we have all of these, then we should see positive consequences of our patients being oriented, having appropriate organ function, and warmth of skin. If our patient's blood pressure is low or perfusion is hindered, then we're going to see signs and symptoms of fainting, peripheral neuropathy, compartment syndrome, ischemic pain, tissue necrosis, decreased organ function, and death. We have quite a few interrelated concepts shown on the concept map. Problems in these areas can create problems with perfusion, and in contrast, optimal functioning in the interrelated concepts will have a positive impact on perfusion. So what we as nurses should do is, number one, to promote healthy behaviors like smoking cessation, diet, and exercise. Number two, we need to know when a patient is at risk for compromised perfusion, such as a patient with diabetes, hypertension, coronary artery disease, or congestive heart failure, or profuse bleeding. Number three, we need to recognize when a patient is experiencing impaired perfusion, which usually results in pain, and we need to respond with appropriate interventions. So the first thing we're going to look at is the subconcept of pump performance, which involves the integrity of the heart itself. And we're going to go into some depth about pump performance. Remember that the heart as a muscle has its own separate circulatory system, the coronary arteries. They are necessary to maintain the integrity of the heart, or the pump, however you want to look at it. When the heart muscle is working, contracting, it is able to function as a pump, pushing blood to the entire body. There are several YouTubes listed on this slide, so take a few minutes to view these before moving on. They will help lay a firm foundation to understand how blood flows through the heart. It shows also how many minutes each one will take. Here are a couple more YouTubes, but these show how the coronary arteries feed the heart muscle. Remember that without functioning coronary arteries, we'll have no pump at all, which means no perfusion, and that means death. First to the heart itself, and then to all the other organs. Here's a short YouTube on cardiac output, which is the amount of blood being ejected by the heart every minute. Stroke volume is the amount of blood ejected with each heartbeat. Therefore, stroke volume times heart rate equals cardiac output. The average cardiac output is 4 to 8 liters of blood per minute. Consider also that we only have 4 to 7 liters of blood within us, depending on our size. So that means that the heart is circulating approximately all of our blood through the body each minute. Cardiac output equals stroke volume times heart rate, and the average heart rate is 70 beats per minute, and the average stroke volume is 70 mLs per beat, which when multiplied equals about 5 liters, or a cardiac output of 5 liters per minute. With exercise and increased heart rate, the heart pumps even more. The point in explaining that is to impress upon you the immense workload of the heart over a lifespan of 80 to 100 years. What they are calling our central blood flow is that which comes from our cardiac output. It includes all the components of the vascular system, the arteries, arterioles, capillaries, venules, and veins, in that order, and then back to the heart. A picture is worth 1,000 words, so here are a couple more YouTubes about arteries, veins, and the peripheral vascular system. Arteries carrying oxygenated blood have strong muscular walls, able to withstand high pressure demands of like a blood pressure of 200. Veins are a low pressure system carrying deoxygenated blood, and you know how some folks can get enlarged varicose veins when the vessels are subjected to too much pressure. The bulk of our blood is in our veins. Arteries make up about 10% of the circulatory system, whereas veins 70% and capillaries only 15%. So when we assess the heart, a primary assessment is to listen to the opening and closing of the 5 valves. If the valves close improperly, excess blood will back up into the most proximal chamber and enlarge that part of the heart. S1 is when systole starts with closure of the mitral and tricuspid valves. The end of systole and start of diastole occurs with the closure of the semilunar valves, which are the aortic and pulmonic, denoted by S2. Erb's point is where S2 is heard loudest. And we will do some practicing with this in lab as well as perhaps in class. This slide further describes what occurs with the sounds that we hear, and there are 2 YouTubes that should help further your understanding. Again, we're going to be practicing listening to these sounds in lab and maybe in class. This is just a diagram of heart sounds with abnormal sounds showing where they occur, S3 and S4. In class, we're going to look at the electrical conduction of the cardiac cycle further. But it doesn't hurt to look ahead. You need to know what the normal P, Q, R, S, T waves represent. This slide shows some of the deadly rhythms. Any interruption in the electrical conduction can lead to a decreased cardiac output, as can occluded or constricted coronary arteries. Also, malfunctioning of the heart valves. All of these are different pathologies having to do with the heart. Other causes outside of the heart that can decrease cardiac output can include loss of blood volume through active hemorrhaging, or maybe vasodilation of all of the venous system, like through an anaphylactic type of reaction. To perfuse our organs, we need a mean arterial pressure that's greater than 60 millimeters of mercury. How we find that is if our patient has a good cardiac output, they will have strong pulses that can be palpated and a blood pressure within normal limits. If their blood pressure and heart rate are within normal limits, they're going to have a good or adequate mean arterial pressure. The heart spins twice as long in diastole, and during that time it is perfusing the coronary arteries, than in systole, which during that time it is perfusing the body. So the way we calculate the mean arterial pressure is that we double the diastolic blood pressure, add it to the systolic blood pressure, divide all by 3, and that gives you the mean arterial pressure, which is only like the average amount of blood pressure that is going through the vessels. And this slide shows you where the major pulses are located. This slide shows you what all the normals are for blood pressure, heart rate, and respirations. For now, you just need to know the adult normals that are in yellow. So how are you going to assess peripheral tissue perfusion? And the answer is you look, listen, and feel. Look for appropriate color, listen to heart sounds, and feel the warmth of the skin, feel the strength and regularity of the pulses, and check capillary refill time. To assess the cerebral perfusion, we can palpate and auscultate the carotid pulse, but since abnormal cerebral perfusion is caused by clots or bleeds in the brain, we primarily assess changing level of consciousness, headaches, irregularity of speech patterns, or movement and discoordination. Postural hypotension is a temporary drop in cerebral perfusion due to a change in body posture. When sitting or lying down, blood can pool in dependent areas. When quickly standing up, the amount of blood carried back to the heart by the veins is decreased, so less blood is pumped out from the heart, resulting in a sudden drop in blood pressure. What we as nurses do about this is to monitor the patient's blood pressure while they are lying down, when sitting up, and then again when standing. And we do patient teaching to have them call for assistance when they're getting out of bed, have them dangle at the bedside, which is to sit at the side of the bed for a minute or two before they do any other movements, and then to hydrate more. We can actually just give them more fluid to drink, and that's going to increase their blood volume and ultimately their cardiac output. We need to make sure that they are not dehydrated, which most elderly folks are. So what is the clinical management of perfusion problems? And it begins with promoting a healthy lifestyle, what we call primary prevention. Primary prevention are the measures taken to provide individuals with knowledge to prevent the onset of a targeted condition. Nurses are to give information and counseling to promote healthy behaviors. And as we assess our patients, we need to ask about diet, the amount of exercise, smoking, drug use, and alcohol habits, and provide patient teaching and community services about each of these. Check out Giddens, page 156, concerning American Heart Association Health Promotion Recommendations. Also page 158, Healthy People 2020 Goals for Heart Disease and Stroke. That is also found in Giddens. Secondary prevention includes screening, early diagnosis, and prompt treatment of existing or suspected health problems. Once problems are identified, nurses work with their patients to reduce and manage controllable risks and help them modify lifestyle choices. An example of secondary prevention is blood pressure screening, and another example is lipid screening. The primary blood tests used for screening are the total cholesterol, HDLs, LDLs, triglycerides, the CRP, and the homocysteine levels, and we will talk more about these in class. What is called tertiary prevention involves the treatment of existing diseases. Nurses help patients plan and make additional behavioral modifications necessary to improve their conditions and intervene to minimize negative effects and prevent complications. So when a patient comes in with a specific problem, we focus first on that problem, asking targeted questions. This slide has common complaints of impaired tissue perfusion listed. When there is time, we need to thoroughly assess the patient's medical history, allergies, and medication use. Specific blood tests are drawn with suspected heart-related problems, including troponin, which is one of the most sensitive markers. This slide shows the onset, peak, and duration of specific cardiac markers. With specific cardiac-related problems, diagnostic radiologic exams are taken, such as chest x-ray, ultrasounds, and arteriograms. And finally, cardiac electrical problems are assessed with a 12-lead EKG and/or stress test. The 12-lead will actually be done first if a cardiac perfusion problem is suspected.